Welcome to the deep dive. Today we are taking on something huge, really critical. We're aiming for a real master level understanding of the drugs used to fight cancer.
Yeah, we're diving deep into your sources today, covering everything from those first sort of cytotoxic agents right up to the latest immunotherapy breakthroughs.
Exactly. And the goal isn't just, definitions. We want to grasp the strategies, the mechanisms behind how these drugs work, and maybe most importantly, how we manage the side effects, the toxicities.
It's like the ultimate insider's guide to oncology pharmacology.
And we absolutely need this deep dive, don't we? The scale of cancer is just immense.
It really is staggering. I mean, look at the stats. Over a quarter of the U.S. population gets a cancer diagnosis sometime in their life. That's what, over 1.6 million new patients every single year needing systemic help?
And that phrase, systemic help, that's key, right? Because surgery and radiation, while vital, they only cure maybe less than 25% on their own.
That's right. The vast majority, they need something systemic, like chemotherapy. Now, we do have amazing successes. Cures, long remissions, and maybe 10% of specific cancers. Think testicular cancer, some leukemias.
Okay.
But for many, many others, chemo achieves regression, shrinking the disease rather than wiping it out completely.
And that difference, regression versus eradication, that's the real challenge. It's why cancer is still the #2 killer after heart disease, even with a 68% overall 5-year survival rate. It's a constant battle.
It is. So let's start with the traditional approach, the core idea of cytotoxicity.
Okay, let's break that down. What's the actual goal? What are these classic drugs trying to do to the cancer cell?
Well, traditional chemotherapy is all about causing a lethal hit cytotoxic event or pushing the cell into apoptosis. That's programmed cell death.
Right.
The attack is focused right at the cellular machinery, mostly targeting DNA, either damaging the DNA structure itself or messing with its synthesis and replication.
So hitting the DNA directly or the things needed to build it?
Exactly, like the synthesis of purines and pyrimidines, those fundamental building blocks for DNA and RNA.
Sounds targeted, but then we hit the big snag, the fundamental flaw you mentioned, non-specificity.
Precisely. I mean, ideally, these drugs would only hit the bad guys, the malignant cells. But most traditional agents, they just can't tell the difference between a rapidly dividing cancer cell and a rapidly dividing normal cell.
Ah, so they hit all fast-growing cells.
Yes. And that's where the toxicity really bites. We're talking about cells in the mouth lining, the gut, hair follicles, and the big one, the bone marrow.
Yeah, the bone marrow suppression is always a major concern.
It is. And this lack of specificity forces this really difficult balancing act. It gives you that incredibly steep dose-response curve we see. Meaning you push the dose higher to kill a bit more tumor, but you drastically ramp up the damage to healthy tissues at the same time. It creates these dose-limiting toxicities. You're constantly weighing the benefit against the harm the host can tolerate.
But things are changing, aren't they? We're moving from just poisoning cells to actually empowering the body's own defenses. That's where these immune checkpoint blockers come in.
Oh, absolute revolutionary. It's a completely different philosophy. These aren't poisons in the same way. They're more like release mechanisms for the immune system.
How do they work?
They block specific checkpoint molecules, like PD-1 or its partner PD-L1. Think of these checkpoints as brakes that cancer cells use to hide from the immune system to tell T cells, don't attack me.
So by blocking the brakes.
You unleash the patient's own cytotoxic T cells. They can finally recognize the cancer cells as foreign and attack them.
Okay, that's a fundamental shift. And the side effects must be totally different, too.
Completely different ballgame.
Yeah.
And this is critical to understand. You're not primarily dealing with the usual chemo side effects, the myelosuppression, the hair loss, the nausea.
So instead, you get problems from an overactive immune system.
Exactly. The adverse effects look like autoimmune diseases, colitis, inflammation of the colon, pneumonitis in the lungs, hepatitis in the liver, various endocrinopathies like thyroid problems.
Wow.
But here's the strategic insight. For cancers that were previously almost untreatable, like advanced melanoma, these autoimmune toxicities are often seen as an acceptable, manageable risk. It's completely changed the outlook for those patients.
That's a huge point. Okay, so we've got the basic mechanisms, poison versus immune boost. Now, let's talk strategy. When we do use chemotherapy, what are the different goals we might be aiming for?
Right, there's a definite hierarchy, which figure 35.4 in the sources lays out nicely. The top goal, the ultimate prize, is cure.
Meaning complete eradication.
Total eradication.
Yeah.
Long-term, disease-free survival. It means killing every single last neoplastic cell. You can sometimes achieve this in highly sensitive cancers, like testicular carcinoma or certain childhood leukemias.
But often a cure isn't realistic. So what's next?
Then the goal shifts to control. Here, you're treating cancer more like a chronic disease. The aim is to extend survival significantly and maintain a good quality of life by stopping the tumor from growing or spreading.
So less aggressive, maybe? More about long-term management?
Generally, yes.
Mm-hmm.
The treatment might be less intense, focused on keeping things stable.
And if the cancer is very advanced?
Then we move to palliation. This is purely about managing symptoms, pain, discomfort. The focus shifts entirely away from extending life and towards maximizing comfort, avoiding treatments with severe toxicity. The goal itself dictates how much risk you're willing to take.
Makes sense. And what about when chemo is used in relation to other treatments, like surgery? There's specific terminology for that, right?
Absolutely. Chemo is essential when the cancer is spread, obviously, or if it's somewhere surgery can't reach. But the timing relative to local treatments is key. First, you have adjuvant chemotherapy.
Adjuvant, meaning helping.
Exactly. It's given after the main local treatment, like surgery or radiation. The idea is to mop up any tiny invisible micrometastases that might be lurking unseen. It's a preventative strike.
Okay. And the opposite, chemo before surgery.
That's neoadjuvant chemotherapy. This can be strategically very powerful. For instance, in breast cancer, giving chemo first might shrink a large tumor enough so the patient can have breast-conserving surgery instead of a full mastectomy.
Ah, I see. The sources mentioned it for bladder cancer too, right? To shrink the tumor first.
Precisely. Downsizing the tumor to make surgery easier or more effective.
And the third timing scenario.
That's maintenance chemotherapy. This usually involves lower doses of a drug given over a longer period, often after an initial, more intense treatment has shrunk the tumor significantly. It's about trying to prolong the remission, keep any remaining cancer cells suppressed.
Okay, timing is crucial. Now, let's dive into the real nitty-gritty pharmacology, how the tumor itself behaves, cell cycles, and this concept of log kill.
Right, we need to understand the target. A tumor's susceptibility often depends on its growth fraction. That's the percentage of cells within the tumor that are actively dividing in the G1, S, G2, or M phase of the cell cycle.
And cells that are dividing faster are more vulnerable.
Generally, yes. Because most chemo drugs target processes involved in replication, cells with a high growth fraction are usually more sensitive.
So, what about the cells that aren't dividing?
Those are the ones in the G0 phase, the resting phase. They're often resistant to drugs that specifically target replicating cells. They just sit there quiescent, weathering the storm. And they're often the reason for relapse later on.
Which brings us to the idea that different drugs work at different points in the cycle. Cell cycle specificity.
Exactly. Figure 35.5 shows this well. Some drugs are cell cycle specific. Think antimetabolites, which mainly hit the S phase, DNA synthesis, or vinca alkaloids, hitting the M phase, mitosis. These are great for tumors with a high growth fraction.
But not so good for slow-growing tumors.
Right. For tumors with a low growth fraction, like many solid tumors, you often need cell cycle non-specific agents. These are drugs like alkylating agents or many anti-tumor antibiotics. They can damage cells regardless of whether they're actively dividing or resting.
The physical size of the tumor also plays a big role here, doesn't it?
A huge role. It's mind-boggling, really. A tumor just 1 gram in size, like a small grape, already contains about 1 billion cells. That's often the point where it becomes detectable, where symptoms start.
1 billion cells.
Now here's a counterintuitive thing. As tumors get bigger, their growth rate often slows down. They outgrow their blood supply, run out of nutrients. So a larger tumor might actually have a lower growth fraction.
Which makes it less susceptible to those cell cycle-specific drugs we just talked about.
Exactly. Which is why debulking is so important strategically.
Removing the bulk of the tumor.
Yes, through surgery, radiation, or even an initial round of nonspecific chemo. When you reduce the tumor mass, the remaining cells often get kicked back into active proliferation. Their growth fraction increases.
Making them more vulnerable to the cell cycle-specific drugs.
Precisely. It's often a necessary first step to set the stage for a cure.
This leads nicely into the log kill phenomenon. This sounds fundamental to dosing.
It is absolutely central. It explains why we give chemo in cycles. Basically, a given dose of a drug kills a constant fraction of the cancer cells, not a constant number.
Okay, unpack that. A fraction, not a number.
So, let's say a drug dose achieves a 3-log kill. That means it kills 99.9% of the cells present. It doesn't matter if you started with 1 billion cells or 1 million cells, that dose kills 99.9% of whatever was there.
Right. So let's apply that to the leukemia example. Diagnosed at 109 cells.
Okay, 1 billion cells. To get the patient into clinical remission, meaning they feel well, symptoms disappear, you need a massive reduction. Often that requires about a 5-log kill.
Which is 99.999% killed.
Exactly. But here's the critical part. Even after a 5-log kill, you've gone from 109 down to 104 cells. That's still 10,000 cancer cells left.
Even though the patient feels fine and looks fine on tests?
Right. And this is where cancer is different from, say, treating bacteria. With bacteria, if you knock the numbers down that low, the immune system would likely mop up the rest.
But not with cancer.
Often not. Tumor cells are sneaky. They can evade the immune system. So the oncologist has to keep hitting hard with more cycles of chemo, even when the patient seems cured, to try and eradicate those last remaining cells. That's the only path to a true cure. It's tough.
Incredibly tough. And another challenge is getting the drugs to all the cells, right? These pharmacologic sanctuaries.
Yes, places the drugs can't easily reach. The classic example is the central nervous system, the CNS, the brain, and spinal cord.
Because of the blood-brain barrier.
Exactly. Many chemo drugs are too large or not lipid-soluble enough to cross that barrier effectively. So if cancer cells, like leukemia cells, are hiding out in the CNS, the systemic chemo won't touch them. It guarantees a relapse.
So how do you treat cancer in the brain?
You need specific strategies. Sometimes it's radiation targeted to the head and spine, or you use drugs known to cross the barrier like nitrosoureas, but often the only way is intrathecal injection.
Injecting directly into the spinal fluid?
Yes, it bypasses the barrier entirely and delivers the drug right where it needs to be. It's a higher-risk procedure, but often essential for tackling those sanctuary sites.
Okay, so we've got kinetics, log kill, sanctuaries. Now, the standard approach to overcome these challenges, combination chemotherapy.
Absolutely, the gold standard. Single drugs rarely cure most cancers that respond to chemo. Combinations are far more successful.
And there's a clear logic to how these combinations are designed.
Oh, yes. 3 main principles. First, use drugs that attack the cancer cell via different mechanisms, different molecular targets.
Okay.
Second, combine drugs with different cell cycle specificities. Hit the dividing cells, hit the resting cells.
Makes sense. Cover all bases. And the third principle relates to safety.
Crucially, yes. Combine drugs with non-overlapping toxicities. This is vital. You avoid putting 2 drugs together that both hammer the same organ. You wouldn't combine 2 drugs that are both severely cardiotoxic, for example.
Because that would limit the dose you could give of either one.
Exactly. By choosing drugs with different side effect profiles, you can potentially give higher, more effective doses of each drug within the limits of what the patient can tolerate.
So the advantages are clear. Better cell kill, hitting different parts of the tumor population, and maybe slowing down resistance. The sources mention RCHOP as a classic example.
RCHOP is the workhorse for non-Hodgkin lymphoma. It's a great illustration. You've got rituximab, that's a monoclonal antibody targeting CD20, then 4 chemo drugs. Cyclophosphamide, an alkylator, doxorubicin, an antibiotic, also called hydroxydonorubicin, vincristine, a microtubule inhibitor, and prednisone, a steroid.
A real mix of mechanisms and cell cycle activity.
Exactly. And notice how it's given, intermittently, in cycles. That break between cycles is critical. It gives the patient's normal tissues, especially the bone marrow, the immune system, a chance to recover before the next round.
Recovery time is built in. Okay. But even with combinations, the cancer can fight back. Let's talk about multi-drug resistance, MDR.
MDR. This is a major hurdle. The most common mechanism involves a protein called P-glycoprotein. You can think of it as a cellular pump.
A pump? Doing what?
It sits in the cell membrane, and it uses energy ATP to actively grab chemotherapy drugs that get inside the cell and pump them right back out.
Wow, so the drug can't even reach its target.
Exactly. The cell just efficiently effluxes the poison. This resistance can be there from the start. That's intrinsic resistance, like you see in melanoma sometimes, or it can develop after the cancer's been exposed to chemo for a while. That's acquired resistance.
And this pump isn't just specific to one drug.
No, and that's what makes it so problematic. It causes cross-resistance. It can pump out a whole range of structurally different drugs as long as they share some basic features, usually a hydrophobic ring structure and a positive charge.
So becoming resistant to one drug might make the cancer resistant to others it hasn't even seen yet, like vinca alkaloids, anthracyclines?
Yes, vincas, anthracyclines, dactynomycin, even older drugs like colchicine. It's a broad-spectrum defense mechanism.
Is this P-glycoprotein just found in cancer cells?
No, and that's a key insight. It's naturally present at high levels in normal tissues involved in transport and excretion. Think kidney tubules, liver cells, lining bile ducts, the intestine, the adrenal gland.
Ah, So maybe that explains why some cancers arising from those tissues are naturally resistant, like adenocarcinomas.
That's thought to be a major factor, yes. They might inherit that high P glycoprotein expression from their tissue of origin, making them intrinsically tough to treat with drugs affected by this pump.
Fascinating. Okay, that defense mechanism is crucial. Now, let's pivot back to the drugs themselves and really focus on the toll they take, the specific organ toxicities. We need to know these inside out and how to manage them.
Right. The general stuff, nausea, vomiting, hair loss, which is usually temporary, mouth sores, bone marrow suppression, those are common and expected, though still very tough for patients. But it's the specific, potentially irreversible organ damage that often limits the dose we can use. We can use that ChemoMan diagram, figure 35.33, as our guide.
Okay, let's start with the heart. Serious risk here.
Very serious and often irreversible. This is the domain of the anthracyclines, doxorubicin and daunorubicin. They cause cardiotoxicity, typically presenting as dose-dependent congestive heart failure.
And we know the mechanism.
It's linked to the generation of free radicals within the heart muscle causing damage. Because it's cumulative and potentially fatal, every patient needs a baseline heart function test, usually an echo or a mid-GA scan before starting these drugs.
Can we protect the heart?
Yes, there are strategies. The main one is a drug called dexrazoxane. It's an iron chelator, and it helps neutralize those damaging free radicals. There are also liposomal formulations of doxorubicin, which package the drug differently to try and target the tumor better and reduce heart exposure. But importantly, combining doxorubicin with other cardiotoxic agents, like trastuzumab, significantly increases that heart failure risk.
Okay, heart covered. Next organ, the lungs.
This points mainly to bleomycin and also busulfan. Bleomycin is infamous for causing potentially fatal pulmonary fibrosis, often called bleomycin lung,
How do you monitor for that?
with regular pulmonary function tests, PFTs, because the damage can be gradual. What's interesting about bleomycin is that it rarely causes significant myelosuppression, so its dose is limited by the lungs, not the bone marrow, which is unusual for chemo.
Got it. Okay, moving down, kidneys and ears.
That's cisplatin. It's highly effective but notoriously toxic. Its dose-limiting toxicity is severe nephrotoxicity kidney damage. It also causes terrible nausea and vomiting and often irreversible ototoxicity, manifesting as high-frequency hearing loss and ringing in the ears, tinnitus.
How do you manage the kidney risk?
Mitigation is absolutely mandatory. Aggressive hydration is key. Flooding the system with IV fluids, sometimes using diuretics, to flush the drug through the kidneys quickly and prevent it from damaging the tubules. Its cousin, oxaliplatin, is generally less harsh on the kidneys and ears.
Okay. What about the bladder? There's a specific toxicity and a specific antidote, right?
Yes, this belongs to cyclophosphamide and its relative ifosfenide.
Mm-hmm.
They can cause hemorrhagic cystitis, bleeding, and inflammation in the bladder. This is caused by a toxic metabolite called acrolein building up in the urine.
And the rescue.
Again, good hydration is crucial, but the specific antidote is a drug called Mesna, sodium mercaptoicane sulfonate, given intravenously. Mesna concentrates in the bladder and directly binds to and inactivates acrolein in the urine, preventing it from damaging the bladder lining.
Essential. Okay, final major system. The nervous system. Neurotoxicity.
Several drugs cause problems here. Vincristine is well known for causing peripheral neuropathy, tingling, numbness, sometimes pain in hands and feet, and it can also cause severe constipation due to effects on autonomic nerves.
Others.
High-dose ifosfamide can cause CNS toxicity related to its metabolite chloroacetaldehyd. And the platinum drugs are also neurotoxic. Cisplatin causes peripheral neuropathy, and oxaliplatin has that very distinct signature, an acute, sharp, cold-induced peripheral neuropathy. Patients might feel pain or tingling in their hands, feet, or throat immediately upon exposure to cold.
That sounds very specific. Does it last?
Usually that acute cold sensitivity resolves within about 72 hours. However, like cisplatin, oxaliplatin also causes a cumulative, longer-lasting peripheral neuropathy with repeated doses.
We absolutely have to pause here and mention that critical safety warning about vincristine.
Yes, this cannot be emphasized enough. Vincristine is fatal if given intrathecally into the spinal fluid. It should only be given intravenously. Because of its neurotoxicity, accidental injection into the CNS causes devastating, irreversible neurological damage and death. Hospitals have strict protocols, special labeling, administering it in small IV bags, never having it near spinal needles to prevent this catastrophic error.
A vital warning. Okay, beyond preventing toxicity, are there specific rescue drugs used after chemo to help normal tissues recover?
Yes, the classic example is Leucovorin rescue after high-dose methotrexate. Leucovorin, also called folinic acid, is a form of folic acid that's already reduced. It bypasses the step blocked by methotrexate, the DHFR enzyme.
So it restores folate metabolism in healthy cells.
Exactly. It allows normal cells, especially in the bone marrow and gut, to resume making DNA precursors, preventing severe megaloblastic anemia and other toxicities, while the methotrexate continues to kill the cancer cells, which often can't utilize leucovorin as efficiently. We also routinely use colony-stimulating factors like GCSF to boost white blood cell counts after chemo and reduce infection risk.
These drugs save lives, but there's a dark side too, isn't there? A long-term risk.
Unfortunately, yes. Because many of these agents work by damaging DNA, they are inherently mutagenic. This means they can, paradoxically, cause new cancers years later. This risk of treatment-induced secondary malignancies is most associated with alkylating agents.
What kind of cancers?
Often acute non-lymphocytic leukemia, ANLL, it might appear 10 years or even longer after the patient was successfully cured of their original cancer. It's a sobering long-term consequence of achieving that initial cure.
That really adds another layer of complexity. Okay, armed with that context, let's systematically walk through the major drug classes now, starting with the antimetabolites. These are the S-phase specific ones, right?
That's right. They interfere with the synthesis of the building blocks of DNA and RNA, or they get incorporated as fraudulent bases. They're structural mimics of normal metabolites.
First up, the antipholates. Methotrexate, Pemetrexate, pralatrexate, methotrexate is the classic.
It is. Methotrexate, MTX, looks like folic acid. Its main job is to powerfully inhibit the enzyme dihydrofolate reductase, or DHFR. This enzyme is crucial for activating folic acid into tetrahydrofolate, FH4, which is needed to make purines and thymidylate essential DNA components. Block DHFR, you block DNA synthesis.
And Pemetrexed.
It's a bit broader, it hits DHFR, but also other folate-dependent enzymes like thymidylate synthase.
We mentioned high-dose methotrexate requires rescue. What about its own toxicity profile, particularly the kidneys?
Right. Kinetically, MTX doesn't cross the blood-brain barrier well, so you need intrathypical doses for CNS disease. It concentrates in the liver and kidneys. The big renal risk comes from one of its metabolites, 7-hydroxymethotrexate. It's not very soluble, especially in acidic urine.
It can crystallize out.
Exactly. It can form crystals in the kidney tubules crystalluria, leading to potentially severe kidney damage. That's why, with high-dose MTX, you absolutely must maintain high urine output with IV fluids and keep the urine alkaline, using sodium bicarbonate, to keep the metabolite dissolved.
Critical management point.
Okay, next group, pyrimidine analogs, 5-fluorosil, 5-FU, capecitabine, cytarabine. Let's start with 5-FU. How does it work?
5-FU is a cornerstone, especially for solid tumors like colon cancer. It needs to be activated inside the cell to 5-FD-UMP. This active form then binds very tightly to the enzyme thymidylate synthase, essentially shutting it down.
And thymidylate synthase makes thymidine,
which is essential for DNA. So blocking it leads to a shortage of thymidine, which triggers thymidineless death in rapidly dividing cells.
Now, 5-FU has a potentially dangerous metabolic issue, doesn't it? Related to an enzyme called DPD.
Yes, this is incredibly important clinically. 5-FU is broken down, catabolized, primarily by an enzyme called dihydropyrimidine dehydrogenase, DPD. But the activity of DPD varies enormously between people due to genetic differences. So some people break it down slower.
Much slower. If a patient is DPD deficient, they can't clear 5-FU effectively. The drug builds up to toxic levels, potentially causing life-threatening side effects. Severe drops in blood counts, pancytopenia, terrible mouth and gut inflammation, mucositis, and severe diarrhea.
Can you test for DPD deficiency?
Yes, and it's becoming more common to do pre-treatment testing or use adjusted dosing strategies for patients known or suspected to be DPD deficient. It's a major safety issue. A notable side effect of 5-FU and its relatives is also hand-foot syndrome, redness, swelling, pain on palms and soles.
What about capecitabine? It's related to 5-FU but taken orally.
Right. Capecitabine is a clever prodrug of 5-FU. You take it as a pill. It goes through several conversion steps. And the very last step, turning it into active 5-FU, is carried out by an enzyme called thymidine phosphorylase.
And the clever part.
Thymidine phosphorylase happens to be found at much higher concentrations in many tumor tissues compared to normal tissues. So theoretically, more of the activation happens right at the tumor site, potentially increasing efficacy and maybe reducing systemic toxicity a bit.
Interesting targeting mechanism. And the last pyrimidine analog here, cytarabine, Ara-C.
Ara-C is absolutely essential for treating acute myelogenous leukemia, AML. It gets converted inside the cell to Ara-CTP, which is a fraudulent nucleotide. It gets incorporated into DNA by DNA polymerase, but it blocks further chain elongation, stopping replication.
Why isn't it given orally?
Because it gets rapidly broken down in the gut and liver by an enzyme called cytidine deaminase. So it has to be given IV or subcutaneously.
Okay, just a quick mention of the purine analogs.
Sure, key players are 6-mercaptopurine, 6-MP, used heavily in maintaining remission in acute lymphoblastic leukemia, ALL. It mimics hypoxanthine. And fludarabine, another nucleotide analog incorporated into DNA and RNA, crucial for chronic lymphocytic leukemia, CLL.
Got it. Now, shifting gears to the real heavy artillery, alkylating agents and platinum complexes. Often cell cycle nonspecific big DNA damagers.
That's the core concept. Alkylating agents work by forming strong, covalent bonds with electron-rich nucleophilic groups on DNA. The N7 position of guanine is a favorite target. This alkylation can cause base misbearing during replication, DNA strand breaks, or, crucially, cross-linking between DNA strands or between DNA and proteins.
Tying the DNA up so it can't function.
Exactly. It physically prevents DNA unwinding and replication. While they can hit cells in any cycle phase, they're most toxic to cells that are actively trying to replicate that damaged DNA.
Cyclophosphamide and ifosfamide are probably the best-known alkylators. They need activation, right?
Yes, they're prodrugs. They need to be metabolized, specifically hydroxylated, by the CYP450 enzyme system in the liver to form their active alkylating species, phosphoramide mustard. This liver activation step is essential for them to work. We already covered their bladder toxicity and the need for mesna.
And some alkylators are designed to cross into the brain.
That's the nitrosoureas, like carmustine, BCNU, and lomustine, CCNU. They're very lipid-soluble, allowing them to penetrate the blood-brain barrier effectively. This makes them vital for treating brain tumors, hitting that sanctuary site.
There's a newer agent mentioned, temozolomide. How is it an improvement?
Temozolomide is related to an older drug, dacarbazine. Both work by forming the same active methylating agent, MTIC. But temozolomide has two key advantages. First, it readily crosses the blood-brain barrier, making it effective for brain tumors like glioblastoma. Second, unlike dacarbazine, it does not need liver CYP450 enzymes for activation. It breaks down spontaneously at physiological pH.
Simpler activation. Anything else?
Yes, it also inhibits a DNA repair enzyme called O6-guanine DNA alkyltransferase, MGMT. Some tumors use MGMT to repair the very damage temozolomide causes, so inhibiting it can boost the drug's effectiveness, especially in tumors with low MGMT levels.
Okay, that covers the alkylators. Now the platinum coordination complexes, cisplatin, carboplatin, oxaliplatin, similar mechanism.
Very similar in principle. They don't technically alkylate, but they form strong covalent bonds with DNA, again favoring guanine bases, creating both intrastrand within one strand and interstrand between the two strands, crosslinks. These distort the DNA helix and block replication and transcription.
Cisplatin was the first, the pioneer, but very toxic.
Extremely. We already detailed its severe nausea vomiting, kidney toxicity requiring hydration, and ear toxicity. It set the stage, but its side effects were a major challenge.
So carboplatin was developed as an alternative?
Exactly. Carboplatin causes significantly less kidney damage, ear damage, and nausea compared to cisplatin. The trade-off is that its main dose-limiting toxicity becomes myelosuppression, particularly hitting the platelets. It's often used when patients can't tolerate cisplatin side effects or the required hydration.
And oxaliplatin, commonly used in colorectal cancer, with its unique neurotoxicity.
Right. Besides the cumulative peripheral neuropathy seen with all platinums, oxaliplatin has that characteristic acute cold-induced neuropathy. It's less nephrotoxic and autotoxic than cisplatin, and generally less myelosuppressive than carboplatin, giving it a distinct niche, especially in combination regimens like FO-FOFLux.
Okay, we've covered antimetabolites, alkylators, and platinums. Let's move to two more major classes: anti-tumor antibiotics and microtubule inhibitors.
The anti-tumor antibiotics are a diverse group, mostly natural products from Streptomyces bacteria. Their main actions involve direct interaction with DNA. This can be through intercalation, where the flat drug molecule slides in between the DNA base pairs, disrupting structure and function, generating free radicals that cause strand breaks, or inhibiting topoisomerases. Most are cell cycle nonspecific, except for bleomycin.
The anthracyclines doxorubicin, daunorubicin are key antibiotics here. We know about their cardiotoxicity.
Yes, caused by free radical generation, leading to DNA scission and membrane damage. They are highly effective broad-spectrum agents, but that heart toxicity is the major limiting factor. Kinetically, they need 5-NE administration and are heavily metabolized by the liver, with excretion mainly in bile, so liver function is important.
And bleomycin, again, with its unusual profile.
Right. Bleomycin is cell cycle specific, hitting cells mainly in the G2 phase, premitosis. It works differently too. It forms a complex with iron, which then generates free radicals that cause DNA strand breaks. We already discussed its lung toxicity being due to low levels of the inactivating enzyme, bleomycin hydrolase, in the lungs and skin.
Okay, antibiotics covered. Now, the microtubule inhibitors targeting cell division itself, mitosis, the M phase.
These drugs interfere with the dynamics of microtubules, which form the mitotic spindle needed to separate chromosomes during cell division. There are two main groups acting in opposite ways.
First, the vinca alkaloids, vincristine, vinblastine.
These drugs bind to tubulin, the protein subunit of microtubules, and actually prevent its polymerization into microtubules. They block the assembly of the mitotic spindle. The cell gets arrested in metaphase because it can't properly align and separate its chromosomes. They are considered S and M phase specific. We already noted vincristine's neurotoxicity. Vinblastine tends to be more myelosuppressive.
And the other group, the taxanes, paclitaxel, docetaxel, they do the opposite.
Exactly the opposite. They also bind to microtubules, but instead of preventing assembly, they promote polymerization and hyperstabilize the existing microtubules. They prevent disassembly.
So the spindle becomes too stable.
Right. It becomes locked, rigid, and non-functional. The cell again gets stuck in mitosis, G2M phase specific, because the spindle can't break down and reform as needed. So vincas block assembly, taxanes block disassembly, both paralyze mitosis and lead to cell death.
Fascinating contrast. And we mentioned paclitaxel needs special handling.
Yes. Because of the formulation vehicle it's dissolved in, originally crema for EL, paclitaxel can cause severe hypersensitivity reactions, flushing, difficulty breathing, low blood pressure. So patients must receive pre-medication before each dose, typically with a steroid like dexamethasone, an H1 blocker like diphenhydramine, and an H2 blocker like famotidine to prevent or lessen these reactions.
Okay, we've covered the major cytotoxic classes. Let's round this out with the more modern targeted approaches. Topoisomerase inhibitors, hormonal agents, and the truly specific biologicals.
Right, topoisomerase inhibitors. Topoisomerases are essential enzymes that manage DNA tangling and supercoiling during replication. They create temporary breaks, allow strands to pass through, and then reseal them. Blocking them causes lethal DNA damage.
There are two types targeting topoisomerase and 2.
Yes. Inhibitors of topoisomerase I cause single-strand breaks. The main drugs here are the camptothecins, irinotecan, and topotecan. They are S-phase specific.
Irinotecan has a particularly notorious side effect profile, doesn't it?
It does. It's converted to a much more potent active metabolite, SN38. The major clinical issue is severe diarrhea. It can cause both an early onset acute diarrhea, cholinergic treated with atropine, and a more severe delayed diarrhea due to gut lining damage, requires aggressive loperamide. Managing this diarrhea is critical.
And topoisomerase 2 inhibitors.
These cause double-strand breaks. The key drug here is etoposide. It blocks cells in the late S to G2 phase.
Okay. Moving to therapies that exploit hormones, steroid hormones and antagonists.
These are crucial for cancers that depend on hormones for growth, like certain breast and prostate cancers. The classic example is tamoxifen for estrogen receptor positive ER+ breast cancer.
It's a SERM-selective estrogen receptor modulator.
Exactly. It acts as an antagonist to estrogen in breast tissue, blocking its growth signal. But critically, it acts as an agonist like estrogen in other tissues, namely the endometrium, uterine lining, and bone.
So it helps fight breast cancer, but increases the risk of endometrial cancer and also blood clots.
That's the trade-off, which is why, especially for postmenopausal women with ER+ breast cancer, the aromatase inhibitors, AIs, like anastrozole and letrozole, are often preferred.
How do they work differently?
In postmenopausal women, most estrogen isn't made in the ovaries, but in peripheral tissues like fat via the enzyme aromatase. AIs block this enzyme, drastically reducing estrogen levels systemically without stimulating the uterine lining. So they don't carry that risk of endometrial cancer. They do have their own side effects, mainly related to estrogen deprivation like bone loss and joint pain.
And for prostate cancer?
We often use GnRH analogs like leuprolide. These initially stimulate but then strongly downregulate the GnRH receptors in the pituitary gland. This shuts down the production of LH and FSH, which in turn drastically reduces the testes' production of testosterone, starving the prostate cancer cells. It's chemical castration, essentially.
Okay, hormonal agents covered. Now let's finish with the truly modern era, the biologicals and small molecules. monoclonal antibodies first.
These are engineered antibodies designed to hit very specific targets, usually proteins on the surface of cancer cells. Examples are everywhere now. Trastuzumab, Herceptin, targets the HER2 receptor, which is overexpressed in some aggressive breast cancers. Rituxan, targets the CD20 protein on B cells, used for lymphomas and some autoimmune diseases. Cetuximab targets the epidermal growth factor receptor, EGFR.
They sound very precise. Any common issues?
Infusion reactions are quite common, especially with the first dose, as the body reacts to the foreign protein. These can range from mild flushing and fever to severe anaphylaxis, so careful monitoring during infusion is standard.
And that odd finding with cetuximab and rash.
Yes, it's been consistently observed that patients who develop a more severe acne-like skin rash while on cetuximab tend to have a better clinical response to the drug. The rash seems to be an indicator that the drug is effectively hitting its EGFR target.
Interesting biomarker. What about the small molecule pills, the tyrosine kinase inhibitors, TKIs?
These are often oral medications, the NIBs, like imatinib, Gleevec, erlotinib, Tarceva, pazopanib, Votrient. They work inside the cell, blocking the signaling pathways that drive cancer growth, often targeting specific mutated kinases that are hyperactive in certain cancers. Imatinib revolutionized CML treatment by targeting the BCR-ABL fusion protein.
Are they generally safer than traditional chemo?
They have different side effect profiles, not necessarily safer overall, just different. They can cause issues like fluid retention, skin changes, diarrhea, fatigue. A key concern with many TKIs is the potential to prolong the QT interval on an electrocardiogram, ECG, which increases the risk of dangerous heart rhythms. So, regular ECGs and monitoring of electrolytes via a CMP, comprehensive metabolic panel, are often required.
Okay. Two more specific classes, proteasome inhibitors.
These are primarily used for multiple myeloma. Bortezomib, Velcade, is the main example. Proteasomes are like the cell's garbage disposal, breaking down unneeded or damaged proteins. Cancer cells, especially myeloma cells, produce a lot of abnormal proteins and rely heavily on the proteasome. Inhibiting it causes these toxic proteins to build up, triggering apoptosis.
Any special precautions with bortezomib?
Yes, a very important one.
Yeah.
It increases the risk of reactivating the herpes zoster virus, shingles. So patients on bortezomib absolutely require antiviral prophylaxis, usually with acyclovir or valacyclovir, for the duration of treatment.
Good to know. And finally, the immunomodulating agents, imivids, also key in myeloma.
Right. This class includes thalidomide and its more potent, generally better tolerated analogs, lenalidomide, Revlimid, and pomalidomide, Pomalyst. Their exact mechanisms are complex and still being fully worked out, but they seem to have multiple effects. Directly killing myeloma cells, inhibiting angiogenesis, new blood vessel formation, and modulating the immune system to enhance its anti-tumor activity.
And the huge warning with these.
The absolute non-negotiable contraindication is pregnancy. Thalidomide caused horrific birth defects in the past, and its analogs carry the same risk. Strict pregnancy prevention programs, like the REMS program in the U.S., are mandatory for anyone prescribing or taking these drugs.
Understood. Wow. Okay, we have systematically covered an immense amount of ground. Principles, kinetics, specific drugs, mechanisms, toxicities, mitigation. Let's try and synthesize those critical life or death toxicities one last time. The Chemo Man recap.
Let's do it. Heart. Doxorubicin, naga-donirubicin, cardiotoxicity, irreversible, watch with echomoga, mitigate with dexrazoxane. Lungs. Bleomycin and busulfan, pulmonary fibrosis, monitor with PFTs. Kidneys, ears, cisplatin nephrotoxicity and ototoxicity, needs aggressive hydration. Bladder, cyclophosphamide, ifosfamide, hemorrhagic cystitis due to acrolein, prevent with mesna and hydration. Nerves, vincristine, peripheral neuropathy constipation, taxanes, peripheral neuropathy, oxaliplatin, acute cold neuropathy and cumulative neuropathy. Gut, irinotecan, severe diarrhea, acute and delayed, managed with altropanilopramide. 5-FU capecitabine diarrhea mucositis, especially if DPD deficient. Bone marrow. Suppression is common with most agents except maybe bleomycin, vincristine.
That's a powerful summary. We've really moved from just knowing names to understanding why things happen, why combinations work, why sanctuaries need special treatment, the logic behind prodrugs like capecitabine or cyclophosphamide relying on enzymes like thymidine phosphorylase or CYP450, the importance of DPD for 5-FU safety, the difference between blocking tubulin assembly versus blocking disassembly,
and the huge shift towards targeted therapies and harnessing the immune system. It's an incredibly dynamic field.
It really is. So Thinking about the future and reflecting on everything we've discussed, we talked quite a bit about that risk of secondary cancers, particularly from the highly effective alkylating agents that are often part of curative regimens.
The delayed consequence.
So here's the provocative thought for everyone listening. We have drugs that can genuinely cure the first cancer, but they carry this inherent risk, maybe 10 or 20 years later, of causing a second treatment-related cancer. How does that knowledge change the conversation, the clinical decision-making, when the patient is young, when they potentially have decades ahead of them where that secondary cancer risk is highest? Do you push for the absolute cure now, accepting that long-term risk? Or do you consider a strategy focused more on long-term control, perhaps with less mutagenic agents, even if it means not achieving that definitive initial cure?
That's the really tough ethical and clinical dilemma at the heart of modern oncology, isn't it? Especially in younger patients. You're weighing the certainty of the current threat against the probability of a future one, induced by your own treatment.
A profound calculation, something to really think about.